I'm Richard Geer, Physician Chief of Surgical Oncology at Sarah Cannon. Latest statistics in women, 1 in 7 will develop breast cancer in their lifetime. Now, it's a little bit of a misleading statistic. It's assuming that the woman would live to 110 years of age, and that would be her, if you lived 110, that would be your lifetime risk, 1 in 7. Over 200,000 women are diagnosed with breast cancer every year. But the good news is that if you look at survival from breast cancer, our survival has become outstanding. And I think it's because tumors now diagnosed at an earlier stage. I think that the treatment, particularly giving multimodality therapy, surgery, radiation therapy, medical oncology, chemotherapy, has decreased our risk of recurrence to the point that we're probably having, if you take a look at a medical oncologist that's in practice for 10 years, and you assume that he gets 100 breast cancer patients a year, at the end of 10 years he'll have over 850 patients in his practice still alive, which is an amazing statistic. It is not as daunting as it used to be. Now, some women have much more aggressive tumors. Some do, but the majority of tumors are now becoming smaller and much more treatable. Male breast cancers are very important. If you do have any family history of a male with breast cancer, that person probably needs to get tested for this BRCA1, BRCA2 gene that is associated with it. So it's just important for the rest of the family members to know that. Generally, stage for stage, it behaves just like female breast cancer. Only about 2,000 of those are diagnosed annually, so it's not a very high portion. But certainly males are at risk and probably need to look for the signs, particularly of a mass of the breast or a fullness, discomfort, something that's new, a change, and alert their physician. Tumors are smaller, but the things to look for would be a mass that you notice persist, mass that's not tender, a change in the skin or a dimpling in the skin or a new dimpling of the nipple that you may notice. It may be something that looks like what we call edema, or the term is called peel d'orange. It's like an orange peel. It's where you get swelling in the breast and it kind of puffs out. Much more common with something called inflammatory breast cancer. Not very common in terms of what you would see. But again, the majority of women in this country now are being diagnosed really with imaging studies, with mammograms, and then leading on to diagnosis. So it's important for your personal health, breast health particularly, to have a good clinical exam a year, to discuss that with your physician, as well as have mammograms on an annual basis. The patient first meets the surgeon basically when an abnormal mammogram is obtained, or an abnormal mammograms basically are all classified into 1 of 5 categories, and women will get back in the mail, or generally the facility will call them when a mammogram is abnormal, and this will generally trigger either additional tests or the visit to see a surgeon. So the surgeon's kind of on the front end of how breast issues are diagnosed and how they're taken care of. The surgeon's role in the treatment of breast cancer is really being the lead of this whole process, as the whole road to therapy goes from surgery through medical oncology, through radiation therapy, along the way. And the surgeon really has, because breast cancer is now becoming so early stage in its diagnosis. Years ago, tumors were diagnosed at a very late stage, and people had large tumors and positive nodes. Now most tumors are almost less than 2 centimeters in size. So we're now starting to see tumors as they become smaller. They're found generally in more imaging studies and really not palpable to the patient anymore. They don't feel it on their breast, and therefore the surgeon gets involved early in terms of their therapy. Most women these days go for usually an annual mammogram above the age of 40. Some women, if they have higher risk factors, will get mammograms sooner. Generally what will happen, you go in for the mammogram, it'll take anywhere from 15 to 20 minutes to do, sometimes longer, and you'll either get a result that's benign or not worrisome. Sometimes it becomes worrisome, and when it does, then we delve into further in the mammograms what are called diagnostic mammograms that can also involve ultrasounds in the breast at the same time, and sometimes will bump us into getting an MR scan of the breast. MR scans of the breast are not a routine thing that we recommend for screening. The only people we recommend for MR scanning for screening patients is going to be someone who has a very high risk of breast cancer, or someone who now has a new diagnosis of breast cancer and we're looking for additional information in the breast. When a woman is now diagnosed with breast cancer, generally they will see the surgeon. The surgeon will then make some decisions about management of this patient. What we have found is that in the last probably 5 to 10 years, there's been a very big push to know that if we present patients to a multidisciplinary team that all has an interest in breast cancer, what we find, we change our management of patients between 30 to 40% of the time. So sometimes we find that just the cookie cutter, one-size-fit-all treatment of cancer is really no longer what's needed. Every woman has, or occasionally male breast cancers, we do see a few of those. Really it's the individual patient, and the treatment is not the same for everybody. A treatment that's good for one patient may not be good for another. And what you'll find, a lot of women will come to see me and they say, yeah, but I had a friend that had that and she didn't do so well. Well, that's not the reason why we shouldn't treat you. It's because there are some unique things that are probably unique to her that influenced how her outcome occurred in terms of that. So what we're finding now is that we're using a team of people. Generally it's the medical oncologist, it's the radiation therapist, it's the radiologist, and we're having these multidisciplinary conferences that generally are starting to occur more on a weekly basis, where we present most of the patients that are diagnosed and then make a decision together about what's the best form of therapy for them.